as well. And so I'm going to turn things over to Dr. Dan Lovell. Dr. Lovell, as I say, if there's any short list of experts on GIA in the world, Dr. Lovell would be on that, and he's been one of my great clinical mentors in my own training. So he's going to talk about some clinical trials that have been recently completed and are ongoing in systemic JIA.
So it's a true pleasure to be here, and something that I take quite seriously. As all of the physicians in this room, we have a passion for treating your children, and it's a responsibility that we think about daily and take very seriously. And so it's a great honor for me to be here to talk to you. What I was asked to talk to you about was clinical trials, and Dr. Bruner and I have organized an international network of pediatric rheumatology centers throughout North America who the centers are dedicated to doing trials of new agents in children with JIA, and it's been very gratifying. For the last 4 or 5 years, we've been able to do trials in systemic JIA, specifically for systemic JIA. So just to get started here, how many of your children have been treated or are being treated with Actimra? Tocilizumab, all right? And what about Ilaris or Canakinra? And then how many have been treated with Anakinra at some point? Yeah, so a majority of you, all right. So how many of your children and you, because it's a whole family project, have participated in clinical trials of these agents? So not, okay. So the reality is that all of us that have used these agents have a debt, I think, of gratitude to the families who are willing to take on the responsibility of testing these new agents. Because when we do a trial of a new treatment, we don't know whether it's going to be effective or not. If we knew the answer to that question, it wouldn't be proper to do the study. So when we start these trials, we sincerely don't know whether the new agent's going to be effective, whether it's going to be safe. And so for brand new agents, it really only makes sense to do that study in families who have failed all the other standard therapies. If there's a standard therapy that's been shown to be effective, then the family should try that first before they go to one of these new trials. And that being the case, I'm going to show you the recent studies of Ilaris and Anakinra, or excuse me, Actimra in kids with systemic JIA. So these are trials that, or these are treatments that were developed and thought about with systemic JIA based on the types of research you've been told this morning. We had very strong scientific background and basis for thinking that these would be effective therapies in systemic JIA with systemic features because of what we knew about what drove the disease. In fact, you can think that the IL-1 and IL-6 blockade are almost designer drugs for this disease because they so tightly fit the pathophysiology or the process of the disease that as if the drugs were specifically designed for this disease. They weren't, but that's how tight the fit is. And as a result of the trials, the drugs have been approved by the FDA, which is a critical step. Because if the drugs are approved by the FDA for systemic JIA, then your insurance companies are required by law to approve the use of those agents in your children. It's only with FDA approval for SJIA that we have a strong case to say it's been approved, this child meets the criteria, set up, or the indications is what the FDA calls it, the indication, condition, and criteria, and therefore this child needs to be approved by the insurance company for treatment. And that's where we have a strong foothold. The reason you have such struggles with Anakinra is because it doesn't have FDA approval for systemic JIA, and therefore the insurance company can say it's experimental therapy, even though there's lots of studies that show that's effective. Since it's not FDA approved, the insurance companies can hide out and say it's experimental and fight approval. So these trials leading to approval is critical for access for families to treat their children. So here's, excuse me, here's interleukin-1 beta in the center here, and then the arrows point to different things that we know interleukin-1 can do. Whoops, that wasn't the one. So if you look up in what would be your upper left-hand corner, you can see that elevated levels of interleukin-1 cause fatigue, fever, poor appetite, probably things that resonate with you with your own children. And then the ACTH, decreased growth hormone, decreased somatostatin, those are all things that are hormones that are important for increase in height. So Dr. Bruner showed you that child with systemic JIA who was quite short. Most of that's from steroids, but it also, we know that systemic JIA, even beyond the effect of steroids, can affect growth because interleukin-1 and interleukin-6 also inhibit these normal hormones the body makes to support and stimulate linear growth. If you look in the upper right-hand corner for acute phase proteins, that's things like cedrate, CRP, ferritin, things like that that are thought to be mediators of acute inflammation or indicators of acute inflammation. In the your lower left-hand corner, you can see that interleukin-1, if it's chronically over expressed or in high levels in the body, can cause damage to the cartilage and the bone. And then you can also see that in the lower left-hand corner, interleukin-1 in many ways acts as a conductor of the cytokine orchestra. So if you increase interleukin-1, then you also increase the level of many other cytokines such as TNF and IL-6 and IL-18, so that interleukin-1, if you express it, then all these others come up at the same time. They're all linked. It's a very tightly integrated network of these cytokines. Conversely, if you lower interleukin-1, then you reverse all these abnormal processes, or at least you have the potential to. So that was the background by which we said, okay, it makes sense to try to test biologics that suppress interleukin-1 in systemic JIA. And what we've seen, not only does the systemic JIA patients have all these features, but systemic JIA patients, based on the data from Virginia Pasquale that Dr. Huggins showed, children with systemic JIA have obvious overexpression of interleukin-1. So we knew that the effects were there as well as the overexpression of interleukin-1. This is IL-6, and you've seen this slide before. There's an investigator in Italy that dedicated about a decade of his life to look at interleukin-6 and did it in animal models, in laboratory assays. And what you see again is interleukin-6 is associated, if you overexpress interleukin-6, it's associated with anemia, the fever shown at the top, the inflammation in the joint. The two mice, the one on the upper, these are in the same batch of litter of mice. The one on The upper mouse that's smaller is a mouse that was genetically engineered to overexpress IL-6 all the time. So you can see that overexpression of IL-6 inhibited the growth in that mouse. IL-6 is associated with MAS. And you can see that in patients with systemic JIA who have an elevated C-reactive protein, which is a marker of inflammation, they also have elevated levels of IL-6. So we had all this experimental data that supported both IL-1 and IL-6 blockade in systemic JIA. So there's an art and a science to doing clinical trials, and we've developed that art and science in pediatric rheumatology much better than many other pediatric subspecialists, and that's why we're able to do these clinical trials with some efficiency. And so one of the things that when you do a clinical trial, you want to see if your children are better, but you have to define what better is. Is better less pain? Is better controlling the fever? Is better getting rid of the rash? And you need to scientifically study these measures of what better is to make sure that they do change. If we said the effect of this treatment to say it's better will change our child from a male to a female, then no drug's going to be successful in that, right? So if you pick measures that are extremely hard to change or unlikely to change or unrelated to the effect of the drug, then you're wasting everybody's time and energy and exposing children to medicines that it's not going, it's not going to work because the measures aren't going to change, right? So there's a whole science to the measuring, developing these outcome measures, and there's been now 15 years of work to develop these outcome measures for your children with JIA in clinical trials, okay? So the measure that we normally work, we say, okay, we decided many years ago, we said, okay, when we do trials to see if drugs get better, we have to have a measure that works, but we also want to use the same measure from one trial to the next so we can see if drug A is similar to drug B, is similar to drug C, because we look at it in the same way. So we came up with this core set of measures that we said we would include in every clinical trial. So we at least have the same road marks along the way. And so the first one is the physician's assessment of how active your child's disease is in an overview, taking in all aspects, the fever, the rash, the arthritis, the fatigue, anything and everything about the disease. They roll into a single score, and it's usually between 0 and 10, with 10 being very severe. And then the next one is your assessment of how well your child is doing overall. So the first one by the physician is a measure of disease activity. We ask you to say, okay, in a general way, in all the ways that this disease can affect your child, how is my child doing? So we ask your input on how your child's doing. The next one, number 3, is a measure of functional ability. So how well can your child do things during a regular course of a day? And then the number of joints with active arthritis, the number of joints that have limitation of motion, and then a measure of inflammation. And then when we do trials of systemic JIA, we also say, is the fever controlled or not controlled? Because fever is kind of a marker of the systemic side of the disease, right? Okay. Now we take all these 6 measures and put them together to say a patient's a responder or a non-responder. So we take and say if 3 of these 6 are improved and no more than 1 is worse, then the patient's a responder. And we take different percents. So we take 30% improvement and we say your child is a JIA 30% responder if you have at least 30%. We also have 70 and 90% improvement. So a 90% improvement means that your child has demonstrated from the time they start the drug to the time you do the assessment, at least a 90% improvement in 3 of those 6 parameters. From my own experience, if a child has exhibited demonstrate an ACR 70 level of response, then for about 2 or 3 days out of the month, they know they have arthritis. The other days, they just kind of go on their business like other kids. And then ACR 100, for example, means 100% improvement or near normalization. Okay, and this is the definition for clinical and active disease, which for many of us is the high water mark. If we can get your child to that point, then we've done our job, okay? And then the ultimate is if we maintain your child in clinical and active disease for 6 straight months, we say they're in clinical remission on treatment. If your child gets to the point where they have all these measures of inactive disease off treatment for 12 months, then we say they're in clinical remission off medication. So those are the definitions we've developed and validated. Okay, so then we had to come up with a study design that's sensitive to the children's needs, but also gives us scientific information about the study. And this is a study design we've used in most clinical trials. So essentially, in this study design, everybody gets treated with the new agent up front. So you come to this trial and you're eligible to be in the study because you have active disease that hasn't responded to standard therapy, right? Which is not a good situation. So we feel that it's not really fair to the child to say, okay, you have a 50% chance of getting placebo in that active disease state. So in this study design, every child gets treated with the new treatment up front, okay? So everybody gets the chance to be treated with it, everybody gets a chance to respond. If at the end of a certain period of time your child is a responder, then we say, okay, we need to figure out whether this is really just a placebo effect or your child is going to get better anyway, or whether this drug really is working. So then we go into the next part of the study, which is where the 2 lines break off. And a certain proportion of the children continue on the active agent. A certain proportion of children are changed from the active agent to placebo or an inactive agent that looks, smells, tastes, feels like the active agent. So that by design, you can't tell the difference between one and the other, and we can't either. So none of us know for sure which agent our child is on. They continued on the active or on the placebo. So we're all kind of equally in the dark here, all right? And your treating physician won't know either, okay? We just are working through this. Now, the only way your child stays in this portion of the study is if they continue to do well. The moment your child meets our criteria for worsening, then you come out of that part of the study, okay? So if you were on placebo and you start to get worse, then you go to the next phase of the study, which is you get back on the active agent that your child responded to in the first place or got better on, okay? So children aren't required to stay in studies for X number of months, whether they're doing good or bad. You only stay in this blinded portion of the study if your child continues to do well. And if your child happens to be on placebo and they're getting placebo injections or placebo infusions or placebo pills, that's somewhat inconvenient, but it's okay because your child's still clinically doing well. So it's justifiable, I think, because your child's still responding well. It's only when they start to do worse that you say it's not fair to keep them on whatever treatment. They need to be put back on what they demonstrate a response to. Okay, all right. So here's that study design that was applied to Anakinra. So you can see up front in what's called D1. No, I'm sorry, I misspoke. This is, no, it is right. So in D1, the first line there, everybody got treated with Anakinra, and then they got randomized to either placebo or Anakinra. That phase of the study was a month, and then at the end of that month, everybody went back on open label treatment. And you only stayed in this double-blind portion as long as your child did well, okay? So here's the results of 1 month of treatment with Anakinra. You can see here's these ACR 30, 50, 70, 100 levels of response I was telling you about, where we use the 6 measures, combine them together, and that sort of thing. So in ACR 30, 83% of the patients on Anakinra and only 25% of patients on placebo demonstrate an ACR 30. So that's a pretty obvious difference in effectiveness. For an ACR 70, 42% of the patients demonstrated an ACR 70 level response and none of the placebos, okay? And these numbers out here on the right is how statistically significant that result is. And so these are all very highly significant results, meaning the difference between Anakinra and placebo are extremely unlikely to be due to chance. For example, the ACR 30 with a p-value of 0.004 means there's 4 chances out of 1,000 that you would see that much difference between the two groups just by chance alone. Extremely unlikely, okay? So these p-values tell you how well the two groups are different from each other. Now, they were able to demonstrate very significant difference between placebo and Anakinra, and they only had 24 patients in the study. So this is a very efficient study design to distinguish if you have a very effective agent like Anakinra, it doesn't take a huge number of patients to demonstrate benefit, okay? This is a study we did with Anakinra. It's an international study. So here are the patients that were allowed to be in the study. In studies of new agents, the patients that are enrolled in these patients are those who have had the disease for several years, because as I said before, it's only fair to put patients in a trial where you don't know if it's going to work if they failed standard therapy. And so generally families have gone through other treatments for a while before they're willing to put their kids in a study like this, which is, I think, fair and appropriate, reasonable way to go about it. So here's the criteria for being in the Anakinra or ILERA study. Everybody had to have fever, they had to have some active arthritis, CRP is a measure of inflammation, and it had to be elevated, and kids who had other manifestations of systemic JIA were allowed to be in. They weren't required to have those, so they were allowed. So here's the characteristics of the patients, and I think yeah, so if you look down, time from SJIA diagnosis to study entry, for this group of patients, on average, it was 2.5 years. So these were not new onset patients, okay? So these are patients who had well-established disease, and even after 2.5 years, they still had very active disease with arthritis, fever, systemic features. So here's the response. In this study, Anakinra or ILERA is given as a once-a-month injection, okay? So in the upper left-hand corner is the response rates at day 15, which is essentially after the first injection of ILERA. So you give one injection, you see them 2 weeks later, and you do the assessment. And you can see that even after the first injection, 76% of the patients met an ACR 30 level of response. 50% of the patients were an ACR 70 level response. Profound improvement. ACR 70 is profound improvement. You saw that at day 15 after the first injection of Anakinra, which tells you this drug is very tightly fit with what causes the manifestations of systemic JIA. So it's a tight fit for what you need to block, okay? And then these are later dates. Month 30, for example, is down in the lower thing, and what you see is the response rates are similar, that with continued treatment, you get continued benefit. So here's the proportion of patients that hit the high water mark, which is clinical remission on medication. So at 6 months, 42% of these severe patients who had long-standing disease, on average 2 years, 40% of them were in clinical remission on treatment. If you look at 12 months, it's 26%, but the number of patients that were still in the study at 12 months is smaller. So you look at how accurate that estimate is, and I think you would see that the accuracy could be a wider range of what it actually would be. But at any rate, you can see that some of these patients do get to clinical remission on medication, but it's not the majority. Some do, but many don't, okay? Now, the other aspect of doing any clinical trial is how safe is this agent? And because systemic JIA is different than other kinds of JIA, systemic JIA is very different than RA, then we need to be very careful about the safety signal because we can't generalize from other patients, okay? So here are the things that were seen in this trial. SAE is a serious adverse event and has a specific definition. What you can see, I think the important is that the major ones are flares of the disease which occurred, and then there were patients who got macrophage activation syndrome. So treatment with Anakinra doesn't prevent macrophage activation syndrome. It can still occur, as many parents talked about this morning. There's been subsequent studies to show it doesn't increase the frequency, but it certainly doesn't give you a get-home card free about macrophage activation syndrome. So in conclusion with Anakinra or Ilaris is that the response rate was quite high, children responded quite quickly, and if you continue therapy, then the vast majority of children continue to show benefit. This is a study of Anakinra. So this study used a slightly different study where people went into the study at the beginning either on Anakinra or placebo, so we did randomize children, but we had rules by which they could come out and go to open label therapy. So here's the criteria to get in the study, very similar to what was shown before, except for this study, kids could come in with just arthritis and no systemic features or systemic features and arthritis. So in brief, here's the major outcome we were testing for, which is an ACR 30 plus control of fever, and you can see that that 24% of patients on placebo got to that endpoint versus 85%. So it was dramatically different between the two treatment groups. So you can see in this study on the second line in yellow, these children had their disease on average 5 years before the start of the study, okay? So these children, again, had long-standing, well-established, poorly responsive therapy, and yet they still responded dramatically to the drug. And here's response over time. So you can see that the bottom is 0, and then 2 months, 6 months, 12 months. You can see that by 2 months, around 90% of the children had shown response to the medication. So it's really a dramatically quick, down here is weeks. So at 2 weeks, 90% of the patients had shown some response to the medication. And then here's response over time. This is out to 52 weeks, and so this is the number of joints with active arthritis, and you can see the numbers just continue to decline. This is how much the steroid could be tapered in the children who are in the study. So you can see this is a profoundly important outcome. If you can allow children to take much less steroid, then you avoid all the steroid side effects. And you can see that the mean dose here at the beginning was 0.3 milligrams per kilo, and at the end it was 0.06. And then actually about 60% of the children who are on steroids at the beginning were completely off steroids. So here's the safety signal because both for Anakinra and Tocilizumab, Ilaris and Anakinra, the way it works is suppression of the immune response. That same immune response or a similar immune response is important for your response to infections. So there is an increased rate of infections. There doesn't seem to be a significant increased rate of serious infections. And again, in the Tocilizumab study or Anakinra study, there were patients who developed macrophage activation syndrome. And again, it doesn't seem to increase the rate of macrophage activation syndrome, but it can still occur. These are the labs. So a small proportion of patients in the studies got low neutrophil counts, low platelet counts, and about 6% got some elevation of liver enzymes. So these are tests that need to be monitored in children who are on Anakinra. So the conclusions from the Anakinra study was that it was effective in a large proportion of children. The clinical effect was very quick. It allowed half of the children to get completely off steroids by the end of the first year. And at the end of 1 year of treatment, over half of the children were in clinical inactive disease. So let's talk about MAS and IL-1 and IL-6 treatment. So as you can see in both the clinical trials, there were children on treatment who developed MAS. They've done subsequent analysis of those patients and other patients to come to the conclusion that certainly treatment with these agents doesn't increase your risk for MAS, but there's still a risk. The things that induce MAS are mostly the same. Intercurrent infections, so viral or bacterial infections, or flare of the systemic JIA are the triggers for children to get MAS, just like it is in children who aren't on this treatment, okay? The manifestations of MAS may be slightly different with Ilaris, or excuse me, Anakinra. The fever may be slightly decreased, and the lab abnormalities may be a little more profoundly abnormal at the time of the diagnosis of MAS. The treatment for MAS in children who are on IL-1 and IL-6 are exactly the same as if they weren't. Higher dose steroids and cyclosporin is necessary. So this was brought up by, I think, Dr. Bruner, with the idea that, as I told you, these clinical trials are done in children who had their disease for a long time, right? What happens if you take these highly effective agents, IL-1 blockade, IL-6 blockade, and introduce them in the treatment of your child almost immediately after the onset of the disease? Is there a bigger impact? Do more of these children do well than if you in the clinical trials where it's long-standing treatment-resistant disease? And the answer, I think, from a number of different studies is yes, it's true. And the hope is by early treatment, more of these children can come off their treatment because you've interrupted this disease buildup process early. But I say at the current time, we haven't done the kinds of studies to definitively answer that question. There's a suggestion from the trials that yes, early treatment aggressively will hopefully get more of the children where they can get completely off medications, but we haven't done the kinds of studies to do that. So that's one of the next steps, is to look at use of these biologics early in the disease. And Dr. Huggins talked about the CARA studies are looking at these different treatment plans, and that hopefully will come from that research. We want to see if these biologics will prevent or decrease the chance of your child getting joint damage. Some of you have asked the questions, when is it appropriate to stop the medications? And we really need to do the biomarker studies, and are doing the biomarker studies to answer that question. And we need to look at long-term safety, because your children oftentimes will have their disease more than 1 or 2 years like we follow in the clinical trials. We need 10-year data for safety, 15-year data, and we're in the process of gathering that data. And then there's an entirely new area. Dr. Grom mentioned it, which is the JAK kinase inhibition. And there's a clinical trial for systemic JIA that's starting right now. So this is the potential roles for JAK kinase in arthritis are really potentially multiple. It can be involved in the initiation of the disease process at the very beginning of the disease. So if you inhibit JAK kinase activation, you may play a role in preventing the progression of the disease. Propagation is where the disease goes from that acute first few weeks of the disease into a more of a chronic self-perpetuating disease, and JAK kinase has a role in that also, as well as in tissue damage. So the potential for JAK kinase inhibition to treat arthritis is great. It's been shown to be, a number of these drugs have been shown to be very beneficial for rheumatoid arthritis. We're now initiating studies in polyarticular JIA, and also just at this very moment, a trial in systemic JIA of one of these JAK kinase inhibitors called Tocilizumab. And a refreshing thing is it's a pill. It's not a shot, it's not an infusion. So for the first time in 20 years, we're back to a pill therapy, where your child can take a tablet once or twice a day, instead of having to do injections or infusions, that sort of thing. So this is a trial that's just starting. Sites are being initiated. Kids will soon start to be evaluated for the study. It's being done in a number of pediatric rheumatology centers in North America. So if you have an interest in your child participating in that study, you can talk to Dr. Bruner or I, and we can help steer you to a site that's closest to you that will be participating in the study, because most of the sites for the study have already been identified. So in conclusion, IL-1 and IL-6 are exciting opportunities for treatment. There's lots of other IL-1 and IL-6 biologics are being developed, so soon we will be coming and doing trials in other agents like Tocilizumab and Anakinra, who actually may work better than these drugs, or children will respond to these that may have already failed one IL-1 agent. They may respond to another, because they're not all exactly the same. And then the effect of the treatment in very early onset disease, right at the beginning of the disease, is being assessed. And we are coming up with new treatments all the time. The one that's right now being initiated for study is Tocilizumab. So if you have an interest in talking to somebody about that, Dr. Bruner and I will be happy to talk to you about it. Thanks for your attention. I'm open for any questions either now or during lunch or later. I'll be here for the rest of the day. We've got the important part of the audience here, so maybe it's time to let them go eat, huh? But I'll be open for any questions you may have. Okay. Yeah, I'll be it. Okay. Thank you very much.